Geachte Damen en heren. I will switch to English now, I think, out of respect for the language. About 15,000 women every year in Netherlands face a new diagnosis of cancer. Around the world, it's about 100 times more. Like we talk about 1.7 million of women. And over the years, we have seen this dramatic effect of this disease, like in terms of mortality. And what you see here is a curve of mortality from 1950 to a most recent. And they were increasing until something happened. It was the inception of mammography. And with mammography, we were able to diagnose the cancer sooner and to arrive at a stage where the cancer has not spread. And so the treatments start to be efficient. And this slide, borrowed from Sir Pito in Oxford, show you that today we have half the mortality of breast cancer. And interestingly enough, in 2015, we found that 61% of the patients are diagnosed at an early stage, and the chance of dying of this cancer at 5 years is 1.4%. So we make big progress. So wouldn't it be nice for those women to just go as soon as possible to their normal life? They had a diagnosis of cancer, let's zap the cancer, and maybe the same day go back home. So how do you treat a cancer? Well, a cancer, it's your own cell that has had a couple of genetic modifications and they just multiply indefinitely. When you have a 1 centimeter cancer, it's already 1 billion cells. So the treatments start to involve most of the time surgery, which removes the bulk of the tumor. But as you can see, a couple of cells can be left behind. And this is the reason why, after surgery, you can have 30 to 50% of local recurrence, which sometimes lead to bad events. So this is why, after that, you deliver radiation treatment on the whole breast to get rid of the last cells. And then came our colleague medical oncologists who deliver chemotherapy, hormone treatment, or antibodies to make sure that if any cell has spread far away, we can get rid of them. But these treatments have some drawback. Like a radiation treatment need to deliver small dose every day on a very long time. Why small dose? It's like antibiotics. It can give you all the antibiotics in one glass. You cure, but maybe dead. It's not a good treatment. So I give you small dose to make sure I don't give you side effect. And so most of the treatment is a daily treatment over a month and a half. And it also can generate some acute, painful side effect like skin burn, but also delayed side effect like fibrosis. So there's some hope. Around 2000, people really realized that for well-selected women, most of the time the recurrence is around the surgical cavity. And so maybe what you should do is only treat this area. And there's something interesting in radiation oncology that if you give your radiation on a smaller volume, you can pump more dose without generating side effect. So you can basically accelerate the treatment. And this was proven around 2000, and that's what you did when you want to remove the face of my colleagues. This was proven in 2003 by a technique named brachytherapy, where basically instead of using external beam radiation, you insert a radioactive source inside the tumor and treat the patient. But this treatment, which was an advantage, treating a smaller volume, was delivered 10 times over 5 days, meaning the patient has to be treated twice a day over 5 days. And to be honest, it's really an invasive treatment. So we need to make better. We need to push further. Around 2004, our team, we start to say, why don't we use a simpler way of doing brachytherapy? We do that for prostate. We do permanently implanted seeds of very low energy radio emitter. And we develop a very complex device to enable the very precise insertion into the breast. And so we transform this technique into a simple 1 hour technique. Patient come in, have a general anesthesia or light sedation, have the insertion, and receive their treatment home. And what you see here is an example of the technique where we insert basically the stranded seeds around the surgical cavity using an ultrasound to make sure we're extremely accurate. We basically spare most of the breast. Here's an example of a patient that has been treated. You see the heart in the middle, you see the breast, you see the gray area, which is where the surgery has been done, and all around you see the white dot, which are the seeds that deliver the treatment. This treatment, we published the result last year. About 134 patients were treated, and the local recurrence were very low, 1.2%. Better or similar to external beam radiotherapy. And this treatment has a lot of appeal for women. And it has helped us also to communicate with company, to bounce on the key lecture today, with some company developing some treatment planning software. We develop them for them. And so some other companies, some startup, starting to promote the technique in the United States. But can we go further? Because here, if we see this technique, we had the surgery. And then you have to wait for the scar to heal. And then you have to do a planning, and then you do your implantation. So it still takes 6 to 8 weeks. Also, we lose half of the patient because after the surgery, very frequently there's a large fluid cavity, and you cannot implant a seed in a fluid cavity. Can we simply get rid of the surgery? Not the surgeon, but of the surgery. And so we start to work on a system where we could do radiofrequency ablation at the same time that the seeds implant. Wouldn't that be a dream? If you could just have your patient have a biopsy, get the surgery done by radiofrequency ablation, and then place the seeds and take your treatment home. It would be a 1-hour treatment altogether. Difficult, because radiofrequency is not easy to develop and things like that. At the same time, with my team, we were also working on nanotechnology. Nanoparticle, we just explained what it is. Let's say that if a nanoparticle would be a dot with a pen, I would be a cancer cell. That tells you the size. So it's really a very small thing, but that can still contain millions of atoms. So just imagine that you will have nanoparticle that you would insert in the tissue that can do a lot of things. And at that time came a new technique in Germany, which is called the nanotherm, which is basically inserting nanoparticle of iron superoxide. And when you put a magnet that is oscillating, you generate heat. And they're treating actually glioblastoma, brain tumor, with this sort of thing. So our idea was, why don't we combine that with our brachytherapy? Can we imagine a nanoparticle that will contain the radiation, but also that could ablate with the heat? So that will be the technique. You will have a patient, you have a biopsy, you know it's an early stage breast cancer, so you will implant your seeds all around the tissue. Then you will bring the patient around this oscillating magnet, generate some heat to ablate the tumor, and down the road, the patient will go home to receive the radiation treatment. And eventually, because it's a still source of radiotherapy, everything will disappear. You mean you will do a surgery without a scar, without deformation, and the patient will just spend 1 hour into the treatment room. So this is an example, pilot data. We have started to do the seeds, the nanoseeds. So this is alginate sort of implants. What you see in pink is a nanoparticle. This is the hand of a PhD student, because research is students. It's not only about the professor, it's also about the students. And here the student has implanted the seeds into a gel, and you can see that after 2 weeks, the nanoparticles are diffusing and distributing the dose everywhere. So the reason why it's very important to have a medical delta is because we are developing such a project in true and very close collaboration with TU Delft. Christina Jakasvili, Antonia Denkova from the TU Delft reactor, and ourselves, Gerard van Roon and myself, are working on this project. Ik heb gezegd.